So in myelofibrosis, which is really, always the focus of drug development in our field, because that's where the unmet need is the greatest with median survivals, in that 6 to 7 year range. So clearly the area, at least when you compare to PV and ET, that is much less indolent and where you need new drugs. There was a lot of excitement as always, or at least as of the last several years. So let's start with CPI 610. This is the bromodomain inhibitor from Constellation. There were three abstracts, one oral by John Mascarenhas on the frontline setting in combination with ruxolitinib, and then one oral by Serge Verstovsek on the combination again, but in an add-on setting, and one poster by Moshe Talpaz on this drug alone in the setting after ruxolitinib. I've been involved with this drug, and I'm on a couple of these presentations. But let's talk about John's presentation, which is important because this is the direction the company is taking. They're going to develop this drug in the frontline setting in combination with ruxolitinib. So I guess that's what makes this particular abstract most relevant to the drug's future path in development. So the manifest trial has three arms, and again, those were the three abstracts I just alluded to. And John's oral presentation was on arm 3, the JAK inhibitor-naïve patients. In these patients, you saw a 67% spleen response rate and a 57% symptom response rate at 24 weeks. To the combination of CPI 610 and ruxolitinib, which is a high bar. It is this combination is setting, because with Rux alone, you expect spleen and symptom response rates in the 40s. 42, 45, 46, something like that. So looks like the combination is truly synergistic in patients, giving you higher rates of spleen and symptom responses at 24 weeks. Obviously, this is comparing across trials. And then also pertinent to mention, a third of patients had an improvement in bone marrow fibrosis. Remember, at an early time point, that's pretty good. It was a grade 1 or more. So of course, grade 2 is even more significant, or I should say 2 grades improvement is more significant, but still 1 grade improvement at an early time point in 1/3 of the patients is important. And then not to mention that this drug CPI 610, or this combination rather, also seems to improve anemia, and which it also does as a single agent in the post-ruxolitinib arm that I was talking about. That one was presented by Dr. Talpaz. So moving on from CPI, a lot of excitement continues with regards to Imetelstat. This is the telomerase inhibitor, IV drug. It's given IV every 3 weeks. Now, remember that there is no new data here. This is data on the same set of patients that we've heard about before. I think we first heard this data at ASH 2018 in an oral presentation by John Mascarenhas. And then there were several abstracts at EHA this year. And again, this year at ASH, there was an oral from John on this, actually 2 orals from John on this, as well as other abstracts. So to sort of summarize, this is, in the post-Rux setting, these are patients who failed Rux. These are not so much your intolerant patients, they are resistant patients. So you might think a bit of a worse population. And you see a 28-month median survival. That's pretty big, because what we expect is 13 to 14 months. So that is very exciting. That's what all the buzz is about. And this drug is going into a phase 3 study in this Rux failure setting with overall survival as the primary endpoint. Now, this is sort of a watershed moment in the field, because we haven't done trials, unlike other cancers, with overall survival as the primary endpoint of a phase 3 pivotal trial. So this is going to be big and new. And then also this drug, there were, again, a lot of abstracts, both at EHA and at ASH. We now have some good pharmacodynamic measures, which I'll, skip for the, for the constraint of time right now. But pharmacodynamic measures that correlate with the clinical benefits. It may be more active in triple negative patients who represent another area of poor risk, high unmet need disease. So a lot of excitement surrounding Imetelstat. And then, people are also watching Bomedemstat, the LSD1 inhibitor, the Navitoclax, the BCL2, BCL-XL inhibitor. Less on those to say right now, because particularly, for example, with the Navitoclax, we actually didn't see new data. So I didn't see anything new beyond the EHA presentation, which is again similar to last year's ASH presentation. And in fact, the data cutoff was February. So it's not really a lot of new patients, but that's another active synergistic combination that we've known of for the past year. There was an update on Bomedemstat, the LSD1 inhibitor, that continues to look interesting. Some new, perhaps genetic markers predictive of response were identified that were also intriguing. But beyond that, I'm trying to think in myelofibrosis, that's it probably for the newer drugs. I'll just mention that there were two interesting abstracts on Momelotinib. Again, not new data, but this drug is being developed, is going into a phase 3 trial, is in a phase 3 trial now, I should say, called Momentum in the second line setting after ruxolitinib, with a primary endpoint of symptom improvement. Patients also have to be anemic because remember, Momelotinib is the JAK inhibitor that uniquely improves anemia. But again, coming back to ASH, there were two abstracts, one oral by Serge Verstovsek, one poster by Jean-Jacques Kilagian on analyses of the same data of Momelotinib that we've had for a few years now from Simplify-1 and Simplify-2, the two phase 3 studies, essentially showing a very robust overall survival benefit for this drug. And then also a very nice efficacy profile across platelet counts. So less than 150, 150 to 300, and more than 300, it seems to show a very nice, efficacy profile across those platelet subgroups.